Hi, everyone. I can see that people are slowly joining us, but I might just get started because we've got quite a lot to get through today. So thank you so much for being here as you come in. I'm Jane Farmer. I'm Professor of Health and Social Innovation. I'm Programme Lead for Social Connection in the Social Innovation Research Institute at Swinburne University of Technology. As I said, I'd like to thank you all for taking the time to be here. And I respectfully acknowledge the traditional custodians of the lands on which we're all meeting today. And I pay my respects to their elders past and present. Today, I'm speaking from the lands of the Wurundjeri people of the Kulin Nation. I'm really happy to introduce this project, which is run as part of our Social Connection programme of work that we have been working on since around 2016. The point of our work on social connection is that it translates research evidence about social connection for application in community practice and health. It takes a strengths-based approach, encouraging people to take small steps and build on connections they already have, including to places. With practitioners and communities, we've co-designed lots of different resources over the years to work with communities on improving connection. And Jasmine is going to give the web address for all these resources at the end of the talk. We'd like to acknowledge funding for this project from the Aged Care Research and Industry Innovation Funds, ARIA, Uniting New South Wales ACT and the Salvation Army. As the speakers want to get through quite a lot, I'm about to hand over to Jasmine, Lucio and Edwina. Please don't run over time, speakers. If you're attending, could you leave your camera on and your microphone off until you're speaking? It's so much better to actually speak to people's faces than to just black blobs with names on. Please stick around for the Q&A at the end of the session and get your questions ready. So without further ado, I'm going to hand over to you, Jasmine, to get the ball rolling.
Thanks, Jane. And please keep us to task if we run over time. Thanks, everyone, for joining us. It's very heartening to hear we had over 200 registrations to this webinar, which is just great to know that there's an interest, in this area. So my name is Jasmine Knox and I'm a researcher at Swinburne Uni, and Edwina Gow and I have been involved. Edwina's from Uniting New South Wales ACT, and we've been involved in developing this toolkit since 2021. It's a unique partnership between two aged care providers and two research partners, so Swinburne and the University of Melbourne and Uniting and the Salvos. And as Jane mentioned, generously funded by Aged Care Research and Industry Innovation Australia. So first, I will outline some of the issues that prompted the development of this toolkit and touch on some of the research about social isolation and loneliness in residential aged care, and speak about the reasons why we should all be thinking about this pertinent issue as a society and for those working in the sector. So social isolation and loneliness has been well established as a global issue. This is reflected in international policy decisions to appoint a minister for loneliness in both Japan and the UK. And in the US, it has been described as a global epidemic. And although social isolation and loneliness can affect all people across the lifespan, the World Health Organization found that older people living in aged care facilities are in the top risk bracket. And many of us in this room would be familiar with the quite shocking findings from the Royal Commission into Aged Care Quality and Safety. So the Commission found that the current aged care system leaves too many older people isolated and disconnected, and that our current system largely does not proactively support older people's social and emotional well-being. And the report highlighted issues to do with staff shortages, high staff turnover rates, and lack of training to support a skilled workforce. And current research shows that half of older Australians living in residential aged care have significant levels of depression. And depression in care facilities is commonly treated with antidepressant medication. And research shows that there's an increase in the prescription of these types of medications in care facilities in Australia, but internationally in the US, the UK. There is some current research that came out of Swinburne Uni recently that showed psychological therapies are effective at reducing resident depression rates, but research has shown that psychological therapies like cognitive behavioral therapy and reminiscence therapy may not be more effective than extra social contact in reducing depression. And social isolation and loneliness has been linked. There's lots of evidence to show that it's linked with increased rates of depression, anxiety, cognitive decline, progression of Alzheimer's disease, and reduced mortality. So if all of these moral reasons for why we should care about this and be trying to affect change, there's also an economic argument to be made. So we spend a lot of money in Australia on aged care. In 2022 to 23, government spent almost 28.3 billion on aged care, with the largest proportion, 58%, being spent on residential aged care. And we are one of the biggest users amongst OECD countries of residential aged care facilities. Almost 20% of the population aged over 80 is in a care facility. And so if we're spending this much money, and with population growth, we're expected in 2030 to 31 to be spending 5% of all government expenditure is on this area. So if we are going to be spending this much money, I think that we could, one, be doing a better job at supporting older people's psychosocial health, and two, we could actually decrease spending by reducing dependence on antidepressant medication, and by reducing depression and social isolation. It also reduces people's cognitive decline. So it could assist with people not relying on such a high level of care required. So also, to add to this, all these lovely interrelated issues, we are a globally aging population. So we're going to be spending more money on aged care in the future. And there's going to be more of us that are going to spend time in care facilities in the future. And I think we need to be asking ourselves, especially in light of the Commission findings, do we feel comfortable with that, given that we know our current aged care system isn't proactively supporting older people's social and emotional well-being? So it could be us, it could be the people we love. So in response to all of these issues, in 2021, we teamed up with the Salvos and Uniting to develop a social connection toolkit. Sorry, a social connection tool. That was the very start of the project. And the tool is essentially a set of questions for aged care staff to find out information about residents' social connections, who's important to them, what they like doing with others, how they like spending time with others, what are the activities, interests and hobbies that they like doing, what are the spaces and places in the facility and in the local community that they like engaging with others. And so the questions are based off social connection research. They're based off a few of our frameworks, and it is, in the pilot, we tested it on 45 residents in 2 care facilities and older people in community care as well. So in the second phase of the project, we received funding from ARIA, and we developed a toolkit. So we revised the social connection tool, we re-co-designed it with resident staff and management, and we reduced some of the questions and the wording, we simplified wordings. And we also developed an easy to use instruction guide. So the guide is for staff to understand how to safely use the tool with residents. So to read out the duty of care statement, to what's the best environment to use it with residents in, And we also developed 5 short social connection e-learning training modules for staff. So these modules are about, explains what social connection is and why it's important for older people's health and well-being, and how to promote it and support it in the context of residential aged care. So what we did in the second stage of the project is we applied for ethics to test it in 4 care facilities in New South Wales and Victoria. So the facilities were a good mix of regional and metro, and they range from 60 beds to 120 beds. And we asked staff and residents to be involved. So we had 80 residents and 29 staff across the 4 facilities. And we asked staff to watch the social connection e-learning modules, to read the guide, and to use the tool with a couple of residents each. It was around 2 to 3 residents each. And then we got them to fill out pre and post surveys to self-evaluate. For residents, it was about evaluating how satisfied they were with social connection in care facilities, how satisfied they were with the rapport with staff and the activities on offer. And for staff, we asked them to self-reflect on their capabilities in related to social connection. So how competent they felt discussing social connection, how well they understood residents' needs. And then we did in-depth qualitative interviews with 16 residents and 12 direct care staff and 3 lifestyle coordinators across the 4 different facilities. So I'm going to jump back on later on and discuss the findings of the evaluation of the toolkit. But Lucio Nacarella from Melbourne University is going to jump on and talk to you about the implementation evaluation findings. So this was about how the toolkit was implemented into the care facility setting, not the evaluation of the toolkit, which I will speak to you later on about. But he has to rush off to another engagement. So he's going to jump on now and talk to you all about that. You out there, Lucio?
I am, and thank you, Jasmine, and special thanks to Jane and Aria. Hi, everybody. I'm Lucio Nacarella. I'm a professor at the University of Melbourne, specifically the Evaluation Implementation Science Unit, Melbourne School of Population Global Health. Now, this is a great opportunity. Jasmine's outlined, wow, there's such a lot of investment of money and people. This is a complex area. There's many interrelated bits. So to actually be funded independently to evaluate the implementation of the toolkit was a gift, but also a challenge. Literally, we had 2 evaluation questions, broad questions. Firstly, to what extent has the toolkit been implemented as intended? Specifically, we're interested in implementation readiness and implementation fidelity. We, not just because we live in the Evaluation Implementation Science Unit, but implementation is so important. We know implementation failure is a key area, so we need to dig deeper into implementation processes. And secondly, implementation context. Yes, this evaluation was done in 2 salvos, uniting care across 4 facilities. So there is variability. So it's important to ask questions about what were the contextual factors, the enablers and barriers that influenced the toolkit's implementation. We had the opportunity to have multiple data collection methods. We were able to sit in the governance committee over 6 occasions. We were able to interview facility managers and lifestyle coordinators, and also observe pairs of staff and residents actually using the toolkit. Now, again, all of that happened across the 4 facilities. Next slide, please, Jasmine. Now, just before I present some very high-level findings, the questions and the frameworks were informed by implementation theories, models, and frameworks. So there's a lot that sits behind here. This is a short presentation, and I'm really happy to take questions. Again, I apologize, I have to leave shortly, but after this webinar. Okay, let's dig a little bit into the implementation readiness and fidelity. And I've just highlighted some key quotes here. I'll let you read the key quotes, but really highlight, look, there was a high level of organizational and staff readiness to implement the toolkit. That was unquestionable. However, the largely clinically focused aged care reforms, increasing workloads upon the staff, and there was some essence of staff revealing duplication of the social connections question with other existing residential aged care assessments, really led to a resistance to engage and implement the toolkit. Now, that's about implementation readiness. In terms of implementation fidelity, Absolutely important. Again, four facilities, two different providers. What we found is that there were differing views between the governance group and actual staff interviews. Staff absences and workloads led to number of staff not being able to participate in the training. Jasmine outlined there was the modules, but there was a whole range of different components to the toolkit. So fidelity is a question mark there. Thank you, Jasmine. Implementation context, probably the most favorite area of mine to really dig deeper, because again, we know transferability of interventions into different settings doesn't just happen. We have to plan for it. But what we found through this evaluation, that there were key internal factors internal to the residential aged care facilities. And I've just alluded to some here. What we call the implementation climate. There was variability in support from the management. There was variability about the communication of the toolkit, and there was variability of resourcing across the facilities. Furthermore, the diversity of the residents, the variability in readiness, capacity to innovation change in residential aged care, and again, the increasing staff competing demands. These came clearly out of the evaluation. So that's internal. External to the residential aged care facilities, I haven't put a quote here, but just to allude to really the alignment with the aged care standard reforms, there was a misalignment. And further, there was continual, again, priorities external that were clinically driven, but were really challenges here and led to tensions in these particular contexts. Thanks, Jasmine. So in summary, my summation was that the implementation of the toolkit has some key strengths strategically, building on the existing partnerships between Swinburne, Uniting Care and Salvos. At an operational level, yes, there is definitely staff commitment to implementation, but the questions still remain about implementation readiness and contextual factors, which actually, when you step back and look at the literature, this resonates with what we know about innovating change in residential aged care. So there is more work and more implications for what we call implementation planning. Thanks, Jasmine. So planning for implementation. Now, please don't turn off your cameras and jump off webinar. Not another framework, I hear my students say. But there are frameworks out there, but we felt it was really important in discussing with Jane and Jasmine and the team for a framework that really alludes to, given the complexity of the factors and these continual challenges to implement social connection initiatives such as the toolkit, there's really need to have some more clarity about how to go forward, how to address these challenges, because they're complex. They're not going to be addressed by one solution. So this framework alludes to there are 4 key purposes, there are 6 key principles, and 4 key implementation foci. So again, as maybe people know or people understand, a guide is a framework. It's a set of principles. It is a guide for. It doesn't tell you exactly what to do, but it's a way of saying, hang on a moment, do we have clarity about the purposes behind the social connections initiatives, whatever it may be, in this case, the toolkit? It's some clear principles, the foundation building blocks for going ahead. In the implementation phase, pre-implementation, not just during implementation, and then these implementation foci. And I've alluded to 4 here. It's important for us to have these discussions before implementing any innovation reforms in aged care, particularly residential aged care, implementation climate, implementation strategies, sustainability and scaling, and last but not least, equitable implementation. Please, I guess my whole world at the moment is that let us not perpetuate inequities in how we develop these initiatives and implement these initiatives. So collectively, I think these 4 areas and key principles and purposes can actually is a way forward. They have policy implications, they have practice implications, and I guess for all of us in residential aged care. Thank you, Jasmine, and thank you, Jane, and I'm happy to take some questions and go forward from here. Thank you, everybody.
Thanks, Lucio. Thanks for squeezing us in. So back to the toolkit evaluation results. So we interviewed 15 staff members across the 4 different facilities, and to evaluate the effectiveness of the tool and its ability to collect useful information about resident social connections. So what we found was majority of staff identified that social connection is important for residents' well-being. So they expressed that social isolation and loneliness was very common for residents in their facilities, and that it was vital that we foster social connection work. And training about social connection by majority of staff, was 14 out of 15, identified that it's important. And almost all, bar one staff member, had expressed that they'd never received any training in this area. So although it's identified as being an important aspect of care, we're also not training staff in this area. And majority of staff, it was 13 out of 15, identified that the tool helped to get to know residents better. And this was a key finding for us in this project, that the staff identified through having the conversations about social connection, that actually fostered social connection itself, because they were having these kind of meaningful moments and able to understand their residents more. And as this quote illustrates, it helped improve our bond, really. For me personally, it helped me know my residents more. The social connection tool is more of an improved way of us getting to know the residents. It's simplified, but the questions are more engaging. So majority of staff identified that the social connection tool is useful. It's useful. Many staff members found that the conversational style of the tool made residents feel more at ease. So they're able to elicit kind of richer information from them. And the tool was identified as being particularly helpful for direct care staff. So personal care workers, personal care assistants and homemakers. As lifestyle staff identified, they are more likely to be having these types of conversations or know this information about social connection. But direct care staff, who make up majority of the workforce and have the most time with residents, don't usually get access to this type of information or opportunities to talk about these types of things with residents. And what I really liked about this project was that staff members from diverse cultural and language backgrounds identified that this tool created a bit of a guide or a template to have these conversations in an appropriate way that created a space for them. I remember one staff member saying, because you can't just walk into somebody's room and ask them how their life is, like it creates a bit of a space in the day to be, having these types of conversations. Majority of staff recommended the tool be adopted after the project finished. So yes, and that it could replace possibly existing tools that lifestyle staff were using. As a lifestyle staff member says here, we have that kind of questionnaire where we say, oh, what kind of activities do you like to do? But the Social Connection Toolkit, I noticed, it's the way the questions were phrased, gets a deeper answer from the resident. And so there were, like anything, there were some challenges. So staff identify that it's difficult to find the time to have even 10 to 20-minute conversations, which points to Lucio's evaluation findings that we are not supporting staff to support residents in this area. Overlap with existing tools used by lifestyle staff, and that came out of the project that this toolkit was more beneficial for direct care staff than lifestyle staff. Not appropriate for all residents. Some residents didn't want to be involved in the project, and staff told us that some residents don't want to talk about social connection. And that is fair enough, because it needs to be a choice. And that it could lead to confronting discussions. So one lifestyle coordinator found that through using a tool with a resident, they felt comfortable to open up and confide in them about a historical abuse that had happened to them. And this underscores the need for appropriate training for staff to know how to refer this on to management and to know how to support the resident through mental health services. And some improvements were suggested. So simplify the wording, reduce perceived duplication, make the tool relevant for residents from diverse language and cultural backgrounds, because social connection means different things in different cultures. So we had asked 29 staff members to do pre and post surveys. So we asked them to rate how satisfied they were with how well you get along with residents, your ability to talk about social connection with residents, your understanding of residents' social connection needs, your level of comfort discussing social connection, your knowledge and understanding of social connection and its benefits. So we use the Wilcoxon-Sign rank test to analyze the results, and we found that there was no statistically significant differences between pre and post survey medians. There was a high median of 5, indicating that staff were very satisfied with each of these areas. And we did reflect that there's a chance that staff could feel encouraged to reflect quite highly if they're rating their own competency, and there's a possibility that management could be made aware. And so the resident interviews. So the resident interviews were interesting because we quickly found out that residents were not able to recall specific details about their experience engaging with the tool with residents. And we realized that this was largely to do with there being quite a large time lapse between staff using the tool with residents and then researchers coming and interviewing residents. In some cases, it was 4 to 16 weeks. So it makes sense. So the evaluation is largely drawn from the staff staff findings, but we were able to glean some interesting insights about social connection more broadly from residents. So residents felt that social connection is very important to their health and well-being and mental health. All residents expressed that. And they also expressed that majority of residents felt comfortable talking about social connection. So there was a little bit of pushback in the pilot from staff who said, residents, they don't want to talk about this kind of stuff. It's too private. And we found in both the pilot and the second project that not only do residents feel comfortable with staff knowing about their social connections, they think it's appropriate for staff to have this information about them so that they can care for them. And they also, majority of residents identified that there are limited opportunities to connect in residential aged care. Many residents wanted to do activities that weren't available, activities like gardening, like cooking, discussion groups, volunteering. And there was even 2 residents from 2 different facilities who had started their own veggie patches. So they were spending their own money on gardening utensils and trying to get other residents involved. And there, I'll just read out this particularly haunting quote from a resident who said, "Sometimes I feel like I might as well be in a prison because you can't do certain things. I feel like I'm in prison, but the only crime I've committed is getting old." So majority of residents highlighted that there were challenges with creating deep connections in residential aged care. So a fear of getting close to other residents who may pass away soon kind of made residents a bit reticent to make those deeper connections. And lack of opportunities to talk to staff about their social connection. There was this pervasive belief that staff were too busy. They're too busy to talk about any of this, or there was too high a staff turnover rate that residents didn't even bother. As this one resident said, I didn't even have a conversation with agency staff as I knew I was never going to see them again. Residents spoke about a discontent with current social programming. So activities like bingo or colouring in activities were expressed as being demeaning or frustrating. And so there was one resident who could remember in crystal clear, accurate detail his experience engaging with the tool with the staff member. So we created a case study from his experience that's in the report, which is a link on the last slide to the report and the toolkit. But John found that using the tool with a staff member allowed him to self-reflect on his own behavior in relation to social connection. So as he says here, I don't find bingo very entertaining. I might not really like hitting the balloon around like a tennis ball, but a different set of people do that. So he realized it's not about the activity, it's about the people that do that activity that he could potentially meet and connect with. And he also found that through using the tool with this staff member, he built rapport with this staff member, and that resulted in him being asked to represent the residents in a committee, in a board meeting. And he felt a sense of pride about being asked to do that. And he attributes that through that opportunity to doing the tool with the staff member and getting to know them better, and the staff getting to know John better. So resident survey results. We asked 80 residents how satisfied they were with how well you get along with staff, your level of control that you have over who you connect with socially, with the social activities that you do with others, and about being listened to when expressing choice in relation to social connection and with your life as a whole. So we used the Wilcox-Sign rank test and paired sample t-test to analyze the results. We found a significant decrease in the mean from pre to post survey for the questions related to residents' level of control in relation to social connection and feeling listened to when expressing choice in relation to social connection. So unfortunately, there was no attribution questions. So it was hard to know how the toolkit, if it at all, affected residents' sense of control or feeling listened to. But some other possible reasons are the longer a person is in a care facility, the likelihood that their physical issues might increase, and this could affect their level of feeling in control or feeling listened to when expressing choice. So there was no significant differences between the pre and post results for the other questions. So now I'd like to introduce you all to Edwina Gow from Uniting New South Wales ACT. Edwina is a manager there, and she's worked on this project with me, developing it from the start in 2021. And she's also on maternity leave right now, but came to join everybody because this is how much she cares about this issue, and I guess believes in this toolkit.
Thank you, Jasmine. Just checking you can hear me. Yeah, awesome. And thank you. I wasn't really going to say I'm on maternity leave, but that's okay. I am. Yes, I am. I am very passionate. So yes, as Jasmine introduced me, my name's Edwina, and I've worked in aged care for just about 21 years, which is quite terrifying, really, to think about. But I started when I was very young, working in the kitchen of a residential aged care facility, and I just loved having conversations with all the residents. And I think maybe because I was so young, they loved talking to me. I don't know, but I just really felt like I formed some real connections. So I continued my work in aged care. I've worked within residential aged care, community care, and independent living. So I've had a variety of experiences. And I'm very, very passionate. As you can see, I'm here on maternity leave to talk about this project, but I'm very passionate about social connection and client wellbeing. It's been my driving force behind why I go to work, or why I did go to work every day, to have a chat and form connections with the older people. So I've just got a couple of questions here to talk about, but the first one is that how is the social connection tool different from other tools typically used in residential aged care? And you've heard from Jasmine and Lucio some of the feedback that we've got, and the different types of responses that people have given us is varied. There are lots of positives about the tool, and there's also some barriers and things as well that have been mentioned by our staff particularly. But what's most important is that here we've designed a tool that's specifically to have that conversation about social connection. And that's something that we haven't really had within, especially in my experience, I haven't had access to a specific tool to have those discussions with residents. I've got a diversional therapy background, so obviously it is one of my strengths to have conversations with individuals and to form a bit of rapport, but I have identified that there's been difficulties with other people, particularly frontline staff, in forming those connections due to those barriers of time and things that we've spoken about. But in having a tool, it really helps and grounds people to have that conversation about social connection. And it also, we need to prioritise this. Social connection is something that's very important to people, as we've seen through the pilot and the project, that people want to have conversations, they want to form connections with people, they want to have a a special person that they can speak to, or just to debrief with about the day. And these conversations can happen with staff members, with family, with other residents within the facility. And these sorts of conversations are just not only being captured, but just not really given the time to have that discussion. So this tool is, it works, it helps to assist the ageist and the ageism experiences that people have within aged care. There's a lot of talk about being a person-centered, providing person-centered care. Yes, as much as that is a focus, I still think there's a lot of work that can be done in that space in terms of person-centered care. Social connection is one of those big things. I believe that, in my experience, again, that there hasn't been a lot of focus on social connection, particularly from family, for example. They're looking at those things that provide, safety and comfort for their loved ones. So they look at things, when are they going to be bathed? When are they going to be showered? Sorry, what are they going to eat? Are they going to have choice? It's all around those sorts of things, but they actually forget about having that discussion about social connection. Staff members, again, as we've touched on, they're working really hard to address these things, but it's hard to have the time to have that discussion on social connection. And what we've found is, by using this tool, it's been a guide to have that discussion. And I think Jasmine, as she touched on it before, that people enjoyed having a guide and to have a space to actually, and a moment to sit down and have that discussion. So I see that it's different because there isn't really a tool to use at the moment. So that's where I think it's an opportunity here that we can, maybe it's not this tool particularly, but we really need to start to have these conversations and to have it influence care within residential aged care. So moving on to the second one, what are the systematic barriers in implementing a social connection tool for on the ground staff? And again, you've heard the feedback from the tool, but just to reinforce from as like a practitioner's experience, that care is highly focused on clinical tasks. As a diversional therapist working in residential aged care, I know that I was generally on the bottom list of things to be done, and people would come and bring them to the activities just for something to do, something to keep them occupied. So when the clinical tasks are done, then they would come out and do those activities with me. It's also, again, I spoke about it briefly, just about the expectations from family, where they expect to have all the other things addressed, and then to actually sit down and have the conversation with an individual is not happening. The second point I want to touch on are the reforms. Again, we spoke about the Royal Commission earlier. It was identified that social connection is important, but still nothing's being done about it. And there's nothing in terms of policies or procedures or funding really that is pushing anyone to make a change in this area and actually focus on social connection as something important to individuals. There is a challenge in raising awareness particularly with direct care staff, as we saw through the project. They didn't always see it as a priority, that they didn't have time to have these conversations. But we saw, as we did from the results from the residents, that they actually want to have these conversations. They want to have a connection with people because they are living day to day in a facility. It's not in their local community. It's not generally not, it's not in their home. They've been removed from that. And what people really want is some connection. So raising the awareness of that, I think, is a big part. And we're not here today to plug the tool particularly, but we're saying that there needs to be the conversation has started, but we need to continue in how we implement change and really make a difference for our people living in aged care. I'll just reflect back on a resident that I had once when I came out of university. And she was one of the first people I really connected with, and she always stayed in her room, so I would go in and have a chat with her. And one of the lines she said that has stuck with me forever is that she said, "Edwina, this is not living, it's just existing." And what I was able to really drill down with her was what was going to be important to her, and it was just to connect with people. And she looked forward to me and my shifts because I was the one that gave her the time and sat down and had that discussion. So that's really my driving force behind being involved in this project. I really hope that yeah, even if it's not this tool necessarily, but that we can really lobby together, lobby to government and make a change. So as we can make these conversations very important and front of mind, particularly, you know, when people enter residential aged care, but not just then, ongoing as well, because some people can stay in residential aged care for quite a long time. So I think it's important that people need to feel like they belong and that they have value. So yeah, I look forward to our question and answer section up next. And yeah, I think that's all from me.
Thanks, Adrina. So in summary, just some key takeaways. Social isolation and loneliness is a challenge in residential aged care environments, and that the Social Connection Toolkit is a strength-based approach to addressing this challenge. And it is free and available to use. The tool, the guide to using the tool, and the e-learning modules are all on our Swinburne University Social Innovation Research Institute website, which there's a link on the next slide. But as Edwina mentioned, the toolkit is not the answer to solving this issue alone. There's so much work to be done in this area, but hopefully it does help to start a broader conversation about the need to proactively support residents' social and emotional well-being. And how do we work collectively? Because I don't think we can wait for government policy or the market to make things better. I think that we do actually, you know, even this project alone, that it was 2 service providers and partnering with researchers from 2 different universities is a good example of this kind of, you know, outside the box thinking or innovative thinking of how we make some positive change. So thank you all for your time and for listening to us. Any questions about the Social Innovation Research Institute or ASC projects or frameworks, please contact Jane, Professor Jane Farmer, and that's her email. And then this is a QR code for the Social Connection Toolkit. So this will be the Swinburne University Social Innovation Research Institute webpage. And then if you go down, I think it's past projects and partnerships, under that tab, that's where all the different components of the toolkit will be. So any questions about that, please feel free to reach out to me. That's my email at the bottom. And now we've got perfectly timed 15 minutes for Q&A.
Yeah, so we need some questions now, people.
Don't be shy. We would like.
Someone did ask if this is being recorded and the slides made available, so I assume that is going to happen.
I can share slides if anyone wants to email me, but I know the recording, yes, it's definitely being recorded. So I think that gets automatically sent to anyone that's registered.
Okay, so any other questions from anybody out there? There is a question. Will AI be introduced to assist with social connection?
I feel like AI is going to be.
Do you have any thoughts about that, Edwina? How about AI in residential aged care?
Oh, well, obviously I'm not the be all and end all of what is going to happen in aged care. I suspect it probably will at some point because AI is everywhere and being used for everything. It's probably not something I've put a lot of thought into as to how at this point, but definitely a very, very good topic to raise at this point.
Yeah, I suppose, yeah, go for it, Jazz. No.
I was just going to say, I can definitely see a space for AI. I think we need to be careful though, as well, with replacing humans with technology in this space, but I think there is a place for AI, you know, ChatGPT or to collate the responses from this tool from residents' wants and needs about social connection and kind of summarize that and put that in a nice little care plan. I think AI needs to supplement human connection, but not replace it, would be my.
I'm thinking about some of the other work that Jasmine has been doing, because Jasmine's been out in Scandinavia looking at residential aged care there and the importance of things like touch and other aspects of connection that kind of become, I don't know if they're even more important when people are losing their abilities, I guess. So as Jasmine said, I think some of our colleagues and ourselves are doing some work looking at AI and social connection, but it needs to be part of care potentially. All right, that was a great question that nearly flummoxed us totally. Any other questions or comments or rising to the challenge? Are other people doing things?
Yeah, or grievances, you know, what have you?
Oh no, let's not start that. I mean, while you're thinking of questions.
Wait, somebody's got their hand up.
Okay.
Wei Jim
Oh
Shen.
yeah, awesome. Go for it, Wei Jim Shen.
Sorry, I just turned the mic on. Yeah, call me Jim. Jim is fine.
Yeah.
So I'm doing my PhD looking at person-centered design of walkers, mobility walkers. And I'm in my data collection phase at the moment. And social isolation is a theme that pops up predominantly around when the devices sort of becomes a barrier to them living their daily activities and social outings, that then creates that social isolation. So I'm just wondering, are there, when I get around to writing the paper for that particular aspect, is there anything that I can reference and start looking at in relation to the work that you're doing?
Definitely.
There will be, yes.
check
We're
out
writing a paper.
Check out our reports, I guess.
Yes.
We are writing a paper. I mean, what you've said has made me think about a conversation I had with an academic colleague the other day who has been researching loneliness of people with chronic conditions, and how she basically said that people have moved from like one persona of themselves to losing things, you know, like sports or capabilities that they've been able to do. And as that happens, they lose connection with those friends, I guess, and with that version of themselves. And I think that as people age, that happens, right? I mean, they lose people in residential aged care. I think this kind of commonplace, but they lose connection with the community that they lived in. They lose connection with their friends. They lose connection with the person they were when they were fully capable, etc. So I think there's probably quite a lot of work out there that you can reference as well as ours.
Yeah, can I jump in? I feel like that's really coming out of my data, my interviews for my PhD, Jim, as well, where residents are speaking about how their physical issues preclude them from engaging or prevent them from engaging with other people. And things like when residents have strokes, where they have speech issues, their mobility issues, that they can't leave the facility. I think that is a really huge issue. And I guess it's about understanding what are the barriers for residents in these environments. So how do you overcome them? How do you bring community into facility? How do you create access that is maybe, you know, through technology to maintaining those connections that they maybe aren't physically able to do as much. But our report, if you use that QR code, our report will also be on that webpage.
Cool.
Okay, there's a few other questions and comments here. So I might first of all jump to Mohammed's question, which I think means, okay, so it says, were there any noticeable differences in the interview findings between the different locations and other differences between the aged care centres?
There were, we did, because we only had 4 sites, we wanted to keep them pretty de-identified, so we didn't compare them. But there definitely were some noticeable differences.
Definitely were.
And that related to economics, I guess, how
much you paid to be
how much you paid. The fancier facilities, the residents definitely described feeling more satisfied with their social connection needs and wants than other facilities that are the less fancy ones. So there is
surprise. What a surprise.
Which this is a
There's
real
inequities. What a surprise.
exactly.
All right, great. I'm sure we can talk more about that if you want to follow up. Okay, Dominica from Melbourne Uni and other places. She's asking, could I ask what are the most effective or innovative elements of the toolkit? Could we use the toolkit in other settings, perhaps with some adaptation? Do you want to talk about, I mean, I personally feel like the e-learning parts of the toolkit are really great because they're short and basic, and it was very quickly kind of consumed by people by staff who thought, I don't know, they had some epiphany moments, I guess, about social connection. I do remember, sorry, I'm dominating this, but I remember you guys telling me that staff had kind of said, oh, we didn't realize what we were doing was a thing, and now we have words for it, now we have language for it. So just the sheer kind of recognition of social connection as a task, I think, like Edwina was talking about, as a valuable task, was important about that e-learning. But over to you guys, what else do you think was innovative about the toolkit?
Can I just quickly lead on from what you were saying, Jane? We've already been asked for the e-learning modules in other areas, like, you know, for mental health organizations have contacted us and said that they have been using these e-learning modules for their volunteers and for their staff. So I think that they are just good kind of short, basic information about social connection for anyone really who, it's not dependent entirely on staff and care facilities. But what felt innovative is probably just really simple, but it seems that we, you know, what we used to do, which is like spend quality time and have meaningful conversations, felt quite unusual in these spaces. And that is largely because we're so focused on clinical care and biomedical health.
So the tool's creating a space for that. But I think another thing that I would say is just that, again, people commented on was the language. So because it's been made with residents and staff, the language is very normal language. It's not like fancy or academic or bureaucratic or organizational. So it's very accessible. So it's kind of like, to me, it's like a comfortable space that's created by the tool where staff and residents could take some time. And it's usually only 5 minutes because people can't find 10 to talk about social connection.
And I'll just jump in there as well. We specifically designed it initially so it was easy, so anyone basically could implement it, because we did talk about in the beginning that if there was a resident that wasn't comfortable maybe at the point of entrance into residential, to have that conversation with people they don't know, that maybe they'd be more comfortable having that conversation or doing the tool with a loved one or a family member or something. And the purpose was that we actually wanted the individual, like the resident, to be asked rather than having the family doing the tool for them. So I think in that respect, it makes it very accessible, very easily used by anyone. And yes, I would say it could be used in other settings, although focused particularly on residential aged care, but it definitely could be useful.
Good job.
Also, I was just going to say, I think there's potential for it to be innovative in how it's used. So it's about the information that you collect and what you do with it. So we did a follow-up session. So we got lifestyle coordinators to have a follow-up social connection session with one resident. So they'd review their answers to the tool and try and find ways that they could implement them. So there was one woman who spoke about, she used to make jewelry. She was really into, kind of art classes and jewelry making. So she wanted to be supported to start jewelry making classes with the other residents. So it's once you have this information, what can you do with it that's going to be person-centered and interesting and based on people's actual interests and innovative?
All right, we might have time for one more question. And apologies to somebody who's asked about smartphones. I don't think we really looked at smartphones or technology. So maybe go to Clara Terezia's question. Could you explain more about the evaluation process for the toolkit? Was there any relevant indicators for the successful solution? And did you measure pre or post loneliness?
Do you want to field that one, Jane?
Oh, look, we didn't measure pre and post loneliness because we weren't really solving loneliness, I guess, with the tool. The tool was more about asking people about their social connections. So I don't think we thought we'd resolve loneliness. Jasmine mentioned we did get some slightly odd results where people said they felt less in control, and something else related to that, which I can't remember. And some people have suggested to us that's because the tool made people think about how in control they were about their social connection and made them realize that they weren't very. And so that's why they gave a more negative answer on the second occasion. But could I explain more about the evaluation process? Well, look, we did use these well-being questionnaires, but ultimately they didn't produce any kind of differences. As Jasmine again hinted during the talk, there could be a lot of reasons for that, like staff didn't want to say anything negative about themselves because they thought other people might look at it, so they didn't. Either that or they really didn't learn anything from the toolkit. And as we say, residents kind of showed these slightly changed results, but in the wrong direction, we might say, in inverted commas. So we have to kind of look at and explain that. But qualitatively, most people, discussed finding the Social Connection Toolkit really useful. And I think that relates a lot to some of the evaluations that have been happening recently about social prescribing, where they haven't actually found quantitative changes in anything, but when they talk to people about their experiences, they generally get really good responses. So I think it's because for each person, it's like a different experience, and a solution would look different for each person. And clearly in this study, we had a lot of different residents and a lot of different staff. So maybe it just needs a bigger, randomized controlled trial to find this out. Just putting it out there. All right, so I think we've come to the end. It's 1 minute to go. I'd just like to thank everyone for being here and hanging on in with us. There's clearly a lot to discuss. You can check out our website and do email us if you've got any more questions, thoughts, or want to find out more. So again, just thanks very much, and see you next time.
Thanks, everyone.
Thanks to Edwina and Jasmine as well. Thanks, bye.
Thanks, Jane. Thanks, Edwina. Bye, everyone.